go ahead and. Hi, okay, thanks, Catherine. So good afternoon, everybody. Welcome to our Disaster Behavioral Health Training Series, where today we are going to talk about mass casualty and mass fatality response, how we've been planning for incidents such as that, or that would create a mass casualty or mass fatality on campus. And I hope that we have some time at the end for questions and answers, because I know that this is probably a topic that is on people's minds and is something that we want to share kind of where we're at in our planning process. I am Courtney Wodtke. I'm the manager of the University of Minnesota Medical Reserve Corps. Today, I'm coming to you from a conference in Chicago, so I'm sorry I'm sitting in my hotel room. And I'm actually at a national MRC conference this week. And so I'm hoping that I will learn a lot of information that I can bring back to all of you and the rest of our MRC and our partners from this national meeting. So next slide, please.
Sorry, thanks, one.
So I mentioned that we're recording the session. I also wanted to just let you know that with the topic of mass casualty and mass fatality comes some things that we'll discuss that might be triggers or make people, possibly uncomfortable. So we just wanted to let you know that we will be discussing some scenarios, but we're not going to be showing any, photos or anything like that that would be disturbing. But in any case, we want you to take care of yourself however you need to during our session today. Catherine, do you want to just talk about for the people in the room where the restrooms are and the exits?
Yes, so for folks in the room here, exits are here, restrooms are out by the elevator, and then the closest stairway is just across the hall for emergency exits. I think that's it for this room.
Thank you. So this is kind of one of our first trainings recently where we've got kind of a hybrid in-person and Zoom. So bear with us as we manage the technology and the kind of trying to engage those that are in person with the group online. I'm going to just quickly introduce our presenters, and then maybe when each of you speak, you could give a little bit more information about your area and your expertise. So Catherine Harrison is the Deputy Director of our Health Emergency Response Office. Van Vu is Van, I don't know your title. Mental health in Boynton. You can talk a little bit more about yourself. And then Adam Wodtke is our senior emergency manager in our Department of Emergency Management on campus. So I'd like to thank all three of you for presenting today with our group and for all of the work that you've been doing within this planning. Next slide. So our agenda, just really quickly, is to talk about kind of the framework that we're using to plan for mass casualties and mass fatalities on campus. What is our behavioral health response on campus, and what is sort of the general behavioral health and mental health ecosystem that we have on campus? What are our roles and responsibilities of our MRC members? We're going to do a group activity to just sort of walk through a scenario and apply some of the stuff that we talk about today. So don't worry, no pressure, but just something to get you engaged a little bit more than just listening to us talk for 2 hours. And then have some time for Q&A at the end. So since this is sort of an academic environment, we're going to just make sure that we've got a few learning objectives for you. So we want you to identify roles and responsibilities in a mass casualty or fatality incident on campus. list 3 resources on campus that provide mental health or behavioral health support, describe the function of our witness support team. Catherine will talk a lot more about that. And then apply at least one skill to the activity at the end of our training today. So with that, again, thank you all for being here. We are excited that there was interest in this topic. Also, just for the presenters to know that I think we've got a blend of both university, MRC, possibly some other university non-MRC people, as well as partners, whether they're MRC unit leaders or others, both within Minnesota and potentially outside of Minnesota. So sort of a blended audience. So I'm going to mute myself and I'm going to turn it over to Adam.
Thanks, Courtney. I'm just going to do a little tech switching here. And while we do that and Adam gets ready to start, for the folks who are online, maybe if you want to pop into the chat, your name, your role, either on campus or outside of the university, and one question you do have as we start about mass casualty response on campus or in higher education settings. If it's not addressed in the presentation, it's always something we can follow up with afterwards. So, and as we get started as well, if you cannot hear Adam on the mic he's using, just unmute yourself and interrupt. We've got a lot going on screen, so I don't want to miss something in the chat, and we'll figure it out. So let's see how this goes. Okay.
All right, first we'll check. Can they hear me?
Can you hear him online?
Yep, we can hear you.
Okay. All right. So
You're
yes,
a little quiet, Adam, so
the Department of Emergency
just maybe
Management.
talk a little bit louder.
That's usually not a problem.
Yeah.
Or get closer to the laptop, maybe.
Or your other lapel, because it's facing this way. So it'll be then facing toward your.
All right, how about now?
How's that? Try
I think that should work.
Is that
I'll
right?
interrupt if we can't hear you.
Okay, yeah, please do, Courtney.
All right, so yes, I'm with the Department of Emergency Management. I've been in emergency management in the fire service for going on 25 years now. I retired as assistant fire chief after 22 years and came to the university to do exclusively emergency management in 2022. I've really enjoyed it so far. A lot of what I do is emergency planning, emergency preparedness, coordinated event stuff. So like for football games or concerts, a lot of coordination with HERO, with the planning for mass casualty stuff, our emergency operations plans, building emergency plans, mitigation plans, all things boring in emergency management falls on my shoulders. And I actually really enjoy it. So I guess we'll take questions as we go, but what we're going to start with is just talk about a few definitions so everybody's on kind of on the same page. When we talk about what mass casualty is, when I'm using these definitions, it's really just FEMA definitions. So depending on the exact setting, you can tweak them a little bit.
Do you mind standing over here?
Yeah,
In this general area?
sure,
Just because then then they can see you on the video in general.
People don't want to see me. So when it comes to mass casualty, basically we're talking about an incident that happens that creates a situation where there's more patients or more medical conditions than the medical resources are able to handle. So, you know, if we use a football game, for example, we have ALS and BLS on site. So even if 5-6 people get hurt, that's not necessarily an immediate mass casualty event. We are prepared to handle an influx of a bad situation. But if a tornado comes through and wipes out that stadium during a football game, it's definitely going to be a mass casualty event. We are not prepared to handle that. So as soon as those on-site medical resources or the initially dispatched medical resources are consumed, that would be considered mass casualty. We need to bring in additional resources. Mass fatality. This one to me got a little bit more wordy as I read it again today. Produces a number or complexity of fatalities that requires special operations. So kind of again to like the mass casualty where there's a number of injuries. In this case, there's a number of fatalities, but just because there's 1, 2, or 3 fatalities, that doesn't really trigger the mass fatality. it could also, it needs to necessarily change the operation. So they might be set up to handle a death or two. But once we get outside of that normal scope where we have to change operations, that's truly a mass fatality event.
Are the slides supposed to be advancing? We still see the definitions slide.
Yep. We're still on those definitions. And then we'll talk about reunification. The one thing I'll talk about reunification, looking, like I'm gonna call it industry-wide or nationwide too. Reunification is a term that they're going away from a little bit. In different college settings where there has been, or not just college, but where there has been, say, active shooters. The term reunification it's implied that you're going to be reunified with somebody. And when people hear that and then they find out maybe their loved one isn't still around, it's created issues. It happened at the University of Michigan State or Michigan State University. So there's an industry standard that's kind of changing from reunification to information and notification center. Whether or not that'll fully switch, that's just something that is trending a little bit now. But by definition, reunification is a process of helping families and children's return to their care after an emergency. All that's saying is, something bad happens, we need to make sure that whether it be minors or even in the case of a university, 18, 19, 20-year-olds are returned back to their parents or the people that typically, care for them or really love them. The next one is a family assistance center, and this is again kind of outside of the scope of the university. It's a secure facility that provides information about missing or deceased people and offers services to victims and loved ones that were somehow involved with that tragedy or with that incident. The biggest difference between Family Assistance Center and Campus Assistance Center is one, the Campus Assistance Center is really more customized or branded to a higher ed setting. And why that matters is because in higher ed, we're unique that we are providing everything. In the city of Minneapolis, they don't necessarily provide housing or dining services or financial aid or the other pile of services that the university provides. So we step it up a little bit and call it a campus assistance center. And we have more of a, call it an a la carte basket of different services that we really need to provide in the event that something bad happens on campus. So Family Assistance Center and Campus Assistance Center are very, very similar. The biggest differences is the amount of services at the Campus Assistance Center is it's a little bit higher level of service just because of what we do provide at the university compared to if something happened at US Bank Stadium down the street or something like that. They do not provide those core services to everybody.
There we go. So the arrows.
So the next step of that, so we have the definitions, we talk about general planning. The most important thing for when it comes to planning is really a comprehensive and collaborative event, right? So when people work together on developing these big plans that affect a huge institution like the University of Minnesota or even a big city like the city of Minneapolis, not one person can really objectively get through those and have a solid plan. You have to bring together teamworks. And then the last bullet is you have to really feel out that whole community. So when we go through this mass casualty and fatality planning that we're doing now, we've engaged everything from facilities to Boynton to really all levels of the university, from public safety down to human resources and some of the global partners too within the university, because if there is a tragedy here, a large scale tragedy, it's going to reach, all corners of the globe in some perspective. So we need to make sure that we have everything provided that we really need to continue to provide for that, for the university and for the people. The one other thing I think is important to planning, historically with emergency management, a lot of times people really went by the book and would write a plan because this is how FEMA or the book says you should write a plan. Today's planning is quite a bit different. And I'm definitely of the belief that your plan should really match how you operate. And you shouldn't try to change your operation based on your plan. And all that says is if you do this task day in and day out, try to match your plan to that, because in the event of a tragedy, it's going to be more likely that you're successful through that event than trying to deal with the tragedy and change your mode of operation. So some of the better plans that I've seen from, and not just stuff that we have here that's local, it really is the plan matches how organizations operate so that it's really more of a solid view. So going through the planning process as we start to prepare, step one is really engaging the stakeholders and identifying them too. So again, going through a large plan like mass casualty and fatality plan, it might seem more simple, but it's a pretty large task. There's internal and external stakeholders. So like for the university, we have a number of, I don't remember, was it like 13, 14 departments that are involved with kind of the core planning of services that we will have to provide. And then there's a number of external agencies that we have to talk to too. So police departments, fire departments, medical examiner, county emergency management, other public health entities. It's a huge planning process because there's a lot going on and it affects our entire community. So we really have to make sure we have, everybody to the table at different parts of the process. The other part of this is really identifying the risks and hazards. What we have to work with here for risks and hazards is probably similar to say what the city of Minneapolis is, but it's just a little bit different. And we want to make sure that our planning process is really customized to our risks and our hazards, right? So we don't probably have to plan for earthquake here. I mean, there's a tiny chance, but we're not going to spend a bunch of time on hurricanes or tsunamis or earthquakes, right? We know weather is our biggest problem, and then active aggressor or some sort of person doing harm to the university. So but identifying those risks, and there's a number of different ways to go through it. If you've heard of THIRAs or HIRAs or HVAs, those are all different acronyms that people use, and there's processes to actually evaluate and score and rank your threats and risks. And one of the most old-fashioned ways is just to look back 100 years or 10 years. What has impacted your organization? And you can start from there. That's just a couple ways to go about it. And then the last two at the bottom kind of go together, in my opinion, conducting training and exercises, and then continuous improvement. Often, again, with training and exercises, I think people put together that it has to be this huge blown up training program or huge exercise that has moving parts, and it really doesn't have to be. When I work with different operating units of the university, basic training and exercises can be done during a staff meeting for 10-15 minutes. So the goal, in my opinion, is the more you can just get in front of people and introduce small segments of what your plan might be or what your planning process is, the more likely they're going to retain it, because you can introduce it to them multiple times at different staff meetings versus having 1 hour session with them once a year. They're going to have that in April and they're going to lose it by the time summer rolls around. So the more you can be engaged with them, even for those short sections, I think is a better way to work through the preparedness process. It just keeps people more engaged. And then that falls back in line with the continuous improvement. And sometimes it's a little out of people's comfort level, but if you find a problem with your plan, don't be afraid to talk about it. The whole point of doing exercises is to look at your plan objectively and say, there's a hole here, or this doesn't really align with what we're trying to do, and adjusting your plan. I have never, ever written a plan that was perfect. I don't intend to ever write. I mean, if I could, that would be fantastic. But you can never necessarily have every scenario planned for. So as you find these little holes and gaps in your plan, you work through the continuous improvement process and develop a better plan or a way to overcome those gaps that you found. So that is kind of a customized way to do it, so there's not a perfect way, again, to go by a book, if whatever way works for you. So if it's after a small incident, or if it's after a drill or a training, find a way to update your plans to make sure that it's on some sort of a reoccurring schedule. So it stays fresh, and also, again, another time to keep it in front of people. So then we come to the responding portion of it. And when we talk about this, we're not necessarily talking about the initial response. So I think a lot of times when you think of response, you think of, lights and sirens, police and fire and EMS racing to the scene with their, lights and sirens. We're past that. So as we're talking about our planning efforts, what we're really talking about is resource allocation, communications, coordinating with external agencies. Although the university is mostly within the city of Minneapolis and, some of St. Paul, we're our own institution, our own agency. We do have to work with those agencies as external partners, and it's can be as simple as picking up the phone or changing a radio channel, but we have to make sure we have those methods predefined so we know how to communicate with those different partners. And then we've already talked about establishing the reunification and notification. DEM, one of our roles also is establishing the EOC. A lot of times I think people get the EOC confused with the incident command post. When there's a large incident, usually for the university, it's going to be the public safety or the police department or Minneapolis Fire that are going to be running the incident command post itself. The incident command post is typically more directly assigned to the incident itself. So whatever bad thing happened, the EOC is not an incident command post. Its job is to be in the background to support that incident command post. So us back in the EOC, our job is to have, the different units that support the university there and at the table. So if we need 100 widgets or 100 trucks or space heaters, whatever it is, we have all those resources gathered in one room, and they have the ability to get those resources. They also have the ability to make decisions financially. So if we need certain groups to work overtime or bring in other groups, me and emergency management, we do not have that authority to do so. Only their supervisors or those department heads have that ability. So that's why we bring them into one room. They can make those decisions together, and then we can support that incident commander with what they're trying to do. So yeah, EOC is Emergency Operations Center. For the university, we have our primary EOC is located right near Huntington Bank Stadium, and then we do have a backup EOC. Each of our 5 campuses actually has a dedicated EOC and a backup EOC. And then open the Campus Assistance Center would be a secondary. So if it was a situation that was deemed needed by both the EOC and the incident commander, that Campus Assistance Center, we would make communications to Hero and activate our Campus Assistance Center and start pulling together all the pieces that we've determined needed for that incident.
Adam, what is HERO?
That's, oh geez. Here, Health Emergency Response Office, right?
Thank you.
Nailed it, first try. So then after that, so through this whole process, then we get into the recovery process. The recovery process is the longest phase typically of any emergency. When you look at these different arrows, and I won't go into these very much because these get very situational depending on the incident, but I'll just go around them and talk a little bit. So we look at victim support. I think Vaughn will talk a lot about what victim support looks like here. Very similar to family support at the university. We're here to make sure that the victims, their families, whether they're students, members of the community, staff, faculty, whatever it might be, but we're here to support them and their families through whatever incident happened. That goes down with the employee support too. The little bit of difference with specific employee support is we've called out a significant section that supports for human resources, so pay, benefits. We know that a large tragedy happens here at the university. people absolutely still need to get paid. We need them to both be safe financially so that they can come back to work when the university is back open. So that's been part of our planning. Medical support is mental health support, physical health support. And at some point it could get into some more long-term planning for medical support, depending on, again, the situation that happens. The last one is FEMA public assistance. That is kind of the biggest piece when we look at from the university. That's where FEMA comes in and says, here is a bunch of money to help you recover from your problem. The catch to that is, in order for that to happen, our losses would have to be an uninsured loss, and there has to be a presidential declaration. So we'll use COVID as an example because most people are aware of that. COVID, the university received a fair amount of money in public assistance, as did most government entities. There's both a presidential declaration and multiple government agencies, pretty much every government agency had some sort of financial loss, and FEMA used some of their disaster assistance funds to support agencies back so that they didn't get hit so hard by COVID. It's a long process. It's a very detailed process. And if you're interested in the public assistance process, there's whole webinars and trainings that have to do with about just how to deal with and apply for public assistance dollars. So, but the key is, it has to be an uninsured loss and there has to be a presidential declaration. Otherwise, those funds are not available to anybody. So it's nice to know that they're there, but it's hard to count on them because it's really out of your control. It's more than just the president saying yes and they sign off on it. They have to hit thresholds. So depending on your community, there's a certain dollar amount your community has to hit to even make that minimum threshold to say, yes, you qualify for the president to even look at it. So it's a little bit more of a complicated process, like I said, but it's there when needed. We put this slide on here, I think, for those that don't work in a lot or work in the space of like public safety or managing incidents, it really helps, in my opinion, paint a good picture of the timeline of what we're looking at. This isn't necessarily hours, days, months. It could be all of those. But when you look at this first response, that's probably the first, 0 to maybe 12, 24 hours if you're talking about a really, really large incident. The tornadoes that went through parts of Iowa yesterday, they are still in that first response period. They're probably maybe getting into the start of some of the reunification, maybe not even official channels are up and working yet, but they're still dealing with managing and stabilizing that incident. A lot of the reunification process won't start until that initial incident or tragedy that has happened is stabilized enough for everybody else to kind of come in and start supporting that incident. Then again, we talked about reunification. Oops, jeez. Well, I lost my mic. All right. No, it's probably can't hear me. And then
Good, Adam. We can hear you. Great.
Okay, thanks. So then in the middle is the combined reunification and family assistance center. All we're recognizing there is there's going to be an overlap with all these processes going on, that multiple channels of support are going to be up and running. So in our campus assistance center is what we'll use here. There's a chance that some of that reunification would be going on in our campus assistance center. And it's possible that some of it would still be happening at local hospitals. That's kind of out of our control, but we recognize that it's likely or possible that those two are going to be going on simultaneously. Once some of that initial, hospital activity is cleared, most of the support is going to be done from our campus assistance center. That is going to be likely one of the more long drawn out periods, right? So, if you look at some of the case studies, Las Vegas is a good example. Las Vegas has had enough tragedy that they have a permanent family assistance center established in downtown Las Vegas. Some of it's through planning, some of it's through, whatever financial planning, whether it's a donation. But they have a center now that's set up whenever something bad happens, they have the ability to, you know, for lack of a better term, flip on the light switch and they have a family assistance center ready to go. Fantastic for them. It's too bad it got to that point, but it's great that they have that resource available to them. And then back to normal operations, and normal operations is likely still going to include some portions of recovery. The other thing that's important about this slide is that all of these don't necessarily have to happen. You can include some of the components and, you know, depending again, what the incident that occurs. And some of them might be longer and some of them might be shorter. You just don't know the duration of each of these. So, depending on the incident, we could have a much longer duration of, you know, if a large tragic fire or something like that, where we're not able to start identifying people that are involved. But the goal is to get to that recovery piece where we get everybody as satisfied as we can with their needs and get the university back to as full functioning, I should say, the university and its community back to as full functioning as possible in the shortest amount of time. That's pretty much it for that one. And then this is the last one. For those that work much in emergency management, we love to work in org charts. This is just a good way to understand kind of the breakdown of what it looks like. So the incident at the top is really the catalyst of everything else, right? So if anytime there's a tragedy, we know that it's going to impact more than just the people that were at or near that tragedy. So we're recognizing in this that it's going to involve those that lost their lives, those that were near it. You know, those are the survivors, right? The injured or not injured, and then those that cared for those people. The other thing that's on here, or not on here per se, is those that might have been involved in an incident. Say we had a large fire in one of the dorms. Those people not only want to hear about their loved ones, they're going to want their stuff back too. So in some of the larger tragedies that have happened across the country, that's one of the other pieces that we keep hearing about is they need to find a way to get all their backpacks or all their personal belongings or their pictures or whatever it is that they want. So that's part of this process, but it's all, you know, it's all part of dealing with the tragedy and making sure that people are given the best tools that we have to recover from it. I think that's pretty much it. Again, so a family assistance center in the bottom right, that's for us, we consider it really the campus assistance center. Those two things go hand in hand. I think that's pretty much it that's it for me, right?
Adam, just to define an acronym that's on this slide, MCFI is Mass Casualty Fatality Incident.
Yep. No. Are you doing this?
Do you want the wireless mic or the lectern mic? It's the button. Okay. Yep. And then. Okay. That
Can
should
you all
go.
hear me now? Yes,
Should be good.
okay,
Yep, sounds good, Vaughn.
thanks. So I want to kind of dive in a little bit to the disaster behavioral health team, just to give you all a sense for how one of the MRC teams, the services and the support that they provide spans across an event. So a little bit of that graph that Adam had shown, where there's a lot of overlap in the different areas and the timelines for how the support centers and how the support services are brought together. Disaster behavioral health is involved kind of throughout this process, right? From the pre-event planning, which is what we've been doing, to the event itself, and then the immediate response of the witness support center, and then first aid responders and hospital, the short-term recovery, the CAC and the family assistance centers, and then of course the long-term recovery. So for disaster behavioral health, a number of the individuals who are volunteering as responders on the disaster behavioral health team may be practitioners in the same community that they're caring for. So the likelihood is pretty high that they'll continue to see some of the same folks that they had cared for in the event of an emergency. For us in particular on this campus, the behavioral health responses that are on campus differ a little bit from the Medical Reserve Corps and the kind of the scope that is, that the response is for the different events. So Boynton and Student Counseling Services, we look at individual cases, right? Obviously, we care for students in the individual therapy setting, group therapy, kind of one-on-one type of situations, and more immediate personal urgent crisis situations. UCRT, which is the University Crisis Response Team, is also individual, though slightly larger. They are specific to providing grief support in the event of a death that might impact a group of students. The Office of Student Affairs works in collaboration with Boynton and SES, and they respond to student emergencies that are slightly larger scale, but still just contained within certain groups of students, or that the emergency incident itself only impacts a smaller group of students and not the entire campus. Whereas the Medical Reserve Corps Disaster Behavioral Health Team is being deployed through the MRC for large scale emergency incidences. In the Disaster Behavioral Health Team, we will have a number of different kind of sibling disciplines that are responding. So we have not only, clinicians, family marriage therapists, social work therapists, and clinical counselors. We'll have psychologists, and we'll have various other providers or professional and non-professional personnel that might come and assist. All of these individuals that are in partnership with one another in a response in an event will be utilizing some of the same core actions that are stemming from the psychological first aid model. The extent to which any one any one person within the disaster behavioral health team might apply an intervention, it's really dependent on their training, right? And the level of support that they're able to provide based on their expertise. Clearly, in a disaster event, we're not sitting there doing therapy. That is not the time nor place. It is specifically to provide support and to try to mitigate the long-term impact of the trauma as the best to our ability. Some of the response modes that we have are kind of the initial response of setting up the command center, providing that support, immediate support to victims and responders, coordinating that event. Some of the push-pull interventions include pushing out hotlines so that we can start to answer questions that might come in, setting up the assistance centers and shelters so that we can attend to some of the immediate needs of the victims and first aid responders. And then, of course, the recovery support that Adam had mentioned earlier. So setting up some of the longer term recovery support that might be needed, some of which can be even longer and protracted. And the one that I have in mind is kind of grief counseling and what's available for counseling support within that community. Like I mentioned, the disaster behavioral health model and the approach that we take is the combination of psychological first aid core actions within the context of trauma-informed care. And how that looks is the 6 core principles of the trauma-informed care of safety, cultural, historical issues, or gender issues, considerations, collaboration, mutuality, peer support, empowerment, voice and choice, and then trustworthiness and transparency. Those core principles line up with the individual core actions for the psychological first aid really well. They line up very well. You can see here how I've sort of paired the different PFAs in accordance with this, how it might overlap with the 6 core principles of trauma-informed care. Our aim is really to be able to ensure that we're engaging individuals, we're connecting with them, we're cultivating a sense of security and safety so that individuals can begin to regain their footing and regain a sense of stability to the best of everyone's abilities, right? And I'm sorry, hang on. Okay, I'm gonna go back, sorry. One of the examples might be that we set up communication and information updates at consistent times so that there's a sense of reliability and stabilization, as well as trustworthiness, right? That individuals, especially victims and families, can begin to predict and know when information will be given to them, and then begin to put together their own personal individual plans, setting up and linking individuals to support. One of the pieces that we are all trying to be mindful of is gathering resources and setting up spaces so that it can help minimize the impact of trauma as much as possible. And within that trauma-informed care framework, doing things like making sure that the area is well lit, making sure that we're attending to some of the accessibility issues that individuals might have, especially individuals within our community, having all gender bathrooms, having different physical ability level access, and then making sure that, culturally, we're attending to some of the needs that may arise depending on the cultural community that we're serving. And the hope is to engage with some of the community stakeholders and individuals that are, working within that community itself to better understand how we can be responsive but culturally sensitive to the needs of that group of people. The other piece is providing practical assistance. Again, cultivating that sense of stability and safety, inquiring about what may be more immediate needs that the individual has, and helping them to begin to kind of prioritize the order of need, and based off of the order of information that we have as well. With practical assistance, it's important to be able to attend to the individual's needs in collaboration with them so that we can cultivate a sense of agency. Having that sense of agency will go a long way into reintroducing an individual's ability to take control of the situation for themselves and to be able to put into motion some of the pieces that might help them heal in the long run. And those things could be, figuring out what their support system looks like, what is available to them, how to get connected to that support. It could also look like identifying, what are the medical needs that have to be attended to right now? What are the comfort needs that need to be attended to right now? If there are children involved, we want to make sure that there are comfort items, comfort toys, weighted blankets for individuals to, again, cultivate that sense of security. And the extent to which it's possible, we want to be able to allow individuals to feel as though they are doing something if they have the capacity for it. Because trauma impacts individuals uniquely, the ability of each person to engage with and assist in an emergency situation is going to vary. So if someone does have that capacity and that we're able to identify those individuals, allowing them to engage with tasks that assist other victims or other survivors might also be really helpful in the healing process. One note that I will put in place here is, I know this is going to be poignant for the witness support. If for information gathering, we want to try to approach that with a lot of care and allow the individual to take the lead on what they are able to share in that moment and that time. Obviously, if they are in the midst of a physical manifestation of their symptoms, it isn't going to make sense to gather information in that immediate space and time. Allowing them to maybe re-regulate in some way could also be helpful. A number of the disaster behavioral health team members are likely versed in mindfulness and re-regulation or grounding techniques that could be really helpful in those situations as well. Okay, so I'm going to dive a little bit deeper into acute grief. because that it can be a very prominent aspect of any emergency disaster behavioral health response. Some of the initial acute symptoms of grief listed here, obviously it varies from individual to individual. The basic needs, we need to ensure that first and foremost, basic needs are met. Medications that need to be taken or that are taken on a routine basis. We need to provide the, food, clean clothes, blanket, comfort items. And then going into the empathic listening. Part of the empathic listening isn't about setting your own agenda. It's going to be important to gather information and to be able to help law enforcement and other emergency responders piece together the events. But empathic listening also allows for the individual to be acknowledged and heard in that circumstance. So there's a little bit of an art to that, of course. But again, allowing the individual to take the lead on the pacing is going to be really important. And I believe that in the long run, it allows us to gather more information because we're able to have more consistent and reliable information that's being relayed. It's important to make sure that we're normalizing the feelings and the acute symptoms that are being expressed within the context of the emergency or the disaster itself. Ensuring that we're not using pathological language. So this is particularly important for clinicians, not using terms like PTSD, not using terms like, you're going to have long-term acute trauma. That none of that is true, right? Because we know that it's a small fraction of individuals who experience trauma go on to develop PTSD. Lastly, connection. A large component of addressing any grief that stems from a disaster and really other trauma symptoms that stem from a disaster is going to be that connection. Reconnecting with available social support, connecting different community support networks, such as faith-based support, referring to additional either behavioral health or psychiatric help in the long run, and then any support groups in the community is going to go a long way in facilitating ongoing recovery and ongoing coping for the disaster itself, for the trauma event. It's important not to ever overpromise. Part of the building trustworthiness and transparency is clearly identifying and sharing what you do know and outlining what you don't know, so that you're not building up false hope and overpromising on things that either you can't follow through with or the emergency team cannot follow through with. A couple of notes here that I want to make regarding the rippling effects of disaster mental health needs. So individuals impacted with prolonged complex grief are going to require significant support, both within their community, but on an individual basis to seek out ongoing counseling and therapy and group support. The literature pretty consistently points to the fact that for prolonged complex grief, it is very beneficial to be able to connect that individual to a group support system, whether that is group therapy or an affinity group or a grief support group. Some of the different incidences across the nation, some of the disasters that have happened have specific ongoing grief support groups that are put together or formed. And that's gone a long way in helping individuals cope with their grief and work through and process the complexity of their grief. There are some potential predeterminants of prolonged complex grief that I'm not going to go into here, but if for any of the clinicians that are interested, feel free to reach out. The same goes for PTSD, making sure that we're connecting individuals that we meet with in the CAC or the FAC, get connected to ongoing care and resources within the larger community is going to be really important in helping that individual process through and be able to manage the PTSD symptoms so that they can return to some resemblance of typical functioning for that person. As a responder, we want to be aware of secondary trauma and then even medical needs and compassion fatigue that follows the work that we do as responders. One of the important pieces that occurs with emergency response is that we're always responding in teams of 2 at the very least, and making sure that there's consistent supervision over the response teams so that support can be provided. One really kind of simple example is, as I mentioned earlier, for many of us practicing within the university community, we may be caring for students in our typical practice and then responding to the emergency for the same community, and then going back into our individual care for students again. So there are a number of kind of overlapping roles and responsibilities. Being able to fall back on supervision within your response team is going to be critical for maintaining some differentiation between your roles and relationships. The other piece that I think is important with secondary trauma is being able to have some process for which the teams and you're debriefing with the team that you're deploying with, so that there is a little bit of overlap in coverage that means that the teams can help support one another.
Awesome. All right, thank you, Vaughn and Adam. So I'm Catherine Harrison. I use she, her pronouns. I'm the Deputy Director of the Health Emergency Response Office, and am part of the core team along with Adam and partners in public safety that's doing some of the planning that he talked about, and that also works with Vaughn and Courtney for the disaster behavioral health planning. So I'm going to talk a little bit about, given their topics, what is the role of MRC members or potential members if you're joining today and you're not a member of our MRC, you're considering, or if you're a member in another jurisdiction, this may look different for your work. So holler if you can't hear me very well. So there's really, sorry, let me go back one. There are really a number of roles that our MRC members play in a mass casualty fatality response. And they happen along a temporal spectrum across time, but also in different spaces, both in person, perhaps at a brick and mortar CAC, or in more of a virtual space, staffing hotlines, doing service delivery, just kind of whatever the needs of the operating units, those departments that have a role in all of those living learning services that Adam mentioned, may need our support with. So the first one, witness and survivor support. This is a highly specialized team that's actually made up of a couple of different groups: our medical station team, our logistics team, and our disaster behavioral health response team. And they are really trained to deploy to the scene of an incident to be like very much as close to first responders as EMS and law enforcement when the situation is safe to do so. So definitely this came about because in large scale law enforcement incidents where there are the needs, as Vaughn mentioned, to gather information from people who saw something and are not either being transported to medical care or have not fled the scene on their own, to provide psychological support as well as other types of support to them while they're providing that information to investigators. So again, the psychological support, which Vaughn talked a lot about, medical support, our medical station team is trained to provide sort of a mid-level care, not first aid, not emergency medicine services, but if you're stuck somewhere for hours and you don't have your inhaler, your insulin, those cardiac meds, maybe you're not injured, to be transported to the hospital, but you do have some scrapes, bumps, bruises, things like that that they can help manage. Logistical support, providing for some of those basic needs, like Vaughn mentioned, food, water, comfort objects, communications. People may flee a scene. I remember after the Las Vegas incident, the large shooting, there were purses, cell phones, all sorts of things left behind as people fled. So providing those means of communication to begin that reunification and incident notification process are also part of that. And then again, supporting the kind of triaging of information so that that process can happen as smoothly and efficiently and not provide additional trauma and being kind of a support with folks as they speak with law enforcement. Very quickly, I'm not going to go through everything on this slide, but just to say that this is the team structure. There are the support units are both folks that are specialized in disaster behavioral health to provide that that psychological support, and then general support members who can help folks like, yeah, you need something to eat, drink, getting that communication set up, anything else that they might need that's more of a general support. And of course, can also practice the tenets of psychological first aid. Our medical unit, as I already talked about, and our logistics lead, we've added some additional capabilities with this team, particularly around data management. So not collecting, definitely not keeping any data, but we know there will be interests from leadership of like how many students, how many people were involved, how many were students, how many were non-university members, are there any children, just to kind of manage some of those high level statistics and information that might be of interest to the public and leadership as we go forward in a response. And then some of the physical assets that we have include a medical kit that has over-the-counter as well as some emergency prescription medications. It has a protocol for how we can obtain very quickly medications through Boynton Pharmacy if we're here on campus, or with our Metro Healthcare Coalition if we're elsewhere for some of those chronic meds that folks might need. And then there's a lot of other logistical materials, as well as a special disaster behavioral health kit that has a lot of those comfort materials and more that Vaughn mentioned. So switching gears a little bit to the CAC, again, I want to just note that as Adam mentioned, this is something that, depending on the needs, the scale, the scope, the severity, might be a physical space we open, but then in parallel, these things can happen virtually. And so I'm mostly going to talk about what that looks like just for simplicity in person at like a brick and mortar CAC. And we have a designated site for that here on campus. We're actively working on how that would look and in a cycle of making those plans and doing trainings. So these are all the things that would be outward facing. And then we'll talk a little bit about what has to happen behind the scenes to make it happen. But as people come into the CAC, there's going to need to be reception, a greeting, an accounting of knowing, should they be here, or do we need to direct them to a hospital reception center? What are the spaces in this place that they're going to need to visit? Are they going to be, heading in a direction of being reconnected with a loved one, or are they going to be heading to conversations with, say, the medical examiner if their loved one is unfortunately deceased? So that reception site is where we can also determine special needs such as language or other physical access and functional needs and get them connected. Also importantly, folks get connected with a family liaison, who is a person that will literally walk through this process with them as they go around and get the different services that they need. And so this is a role that would be staffed by MRC members. Family briefings, that is where folks are going to go to hear information about the incident, about the response, the stage of the response, what's kind of happening, and get a high level overview of what might be going on with their loved ones. That is something that will be conducted by staff and or, such as public safety, emergency management, perhaps public figures, leadership, et cetera. That's not an MRC role, but being there to support families as a family liaison in that situation might be a role that our MRC members will play. Reunification and fatality management. Again, if there's a need to reunify with a loved one, and be part of that process that deals with information. That's like a go-between. There's a lot happening there, is what I'm trying to say, with gathering information, matching people up, getting them connected, and then seeing what other services they need. Separately, if a family member's loved one was deceased in an incident, they will then meet with the medical examiner, and there is a pretty extensive information gathering process. And so psychological support is really critical at that time, that family liaison role, being with folks while they go through that interview process. It might be the case that MRC members, depending on the scale of the incident, would also help in some of that interviewing process with the medical examiner, but really the medical examiner is the lead. That is not something the university has control over. It is a legal process of death notification, and that only they can do. There might be parts of the process, again, where we'll provide some ancillary support, but that would be a pretty in-depth training and selection and clear definition of roles in that process. Victim support services, this is kind of that all-encompassing, do you need housing? How are you going to get your stuff back? Do we have international students whose families won't be here for several days and we're working to get visas and travel, et cetera? Do folks need to get out of their tuition? Maybe they survived, but they might not be returning to classes, or campus is shut down. HR benefits, all of those things, those are the wraparound living, learning, working services and that the university provides, that Adam talked about, that we will have representatives of those departments: registrar, OSA, dining, housing and res life, et cetera. The disaster behavioral health and grief support, as Vaughn mentioned, happens throughout, and then all through all these processes. We have hotlines, different ways folks can access that support. And then finally, ancillary supports are things to help people go through this process. So childcare, if folks are bringing other young children with, we have lactation space and services, again, interpretation and translation services, those types of supports as people move through this process. Of course, to provide all that, we need to have a strong command and logistics infrastructure. So staffing, supplies, that's all pretty clear. Data management, that's a big one. That's going to be processing information about the incident, the stages of the incident, the response, like what do we know kind of qualitatively, and that feeds into the family briefings, as well as is provided to the public through the public information officer, but then also that data around missing, injured, and deceased individuals to be able to reconnect or lead people through that fatality management process. Facilities and communication, of course, we're going to need, internet, phone, Wi-Fi, et cetera, all of that. Safety and security of the site to make sure that the privacy and the dignity of folks going through is really maintained, as well as the safety of the site and the process. Transportation, if needed, working with parking and transportation services to either shuttle people or provide for parking, getting all that set up. And then, as I mentioned, the public information officer, depending on the event, if we do open a CAC, there may be that person at the site, as well as another person in the EOC, or they may just be at the EOC and then connecting more with leadership and the command staff at the site. It just really depends. So this is just to kind of return to a little bit of what Adam started to mention with where we're at. So as I said, there's a core team. It's led by DEM, but it involves also HERO, our office, and DPS, Department of Public Safety, or University Police. We're actively writing plans. I've been doing some plan editing last week, taking a look at our designated site and reaching out to partners. And again, those dozen plus organizational units at the university that are going to have a role in this, and making sure they understand their responsibilities and what support they might need from our teams to be able to fill those. Then the disaster behavioral health response. We are going through a broader planning process for overall response, not just for this type of incident, but any incident on campus and what that looks like. What are the roles, determining recruitment and training for our witness support team, and eventually also for all the other teams that would be involved in a CAC, and then making sure we're ready with our supplies and resources. So we're gonna take just about a 5-minute stretch break, as well as a quick pause for any questions you might have right now about what you've heard, everything that's involved in a big response like this. And then we'll come back together say at 2:15, and so a little more than 5 minutes to apply some of this to a group activity.
Does anyone have any immediate questions? I know in the chat, Catherine, there were just a couple questions from Chris Kaus in terms of how we will work with Hennepin County on our plan. And I think, Chris, the answer to that is we need to get with you and have a meeting and kind of get up to date on where we're at with our planning and our assumptions and where you are in terms of sort of resource and expertise as an extension of us at the university. So maybe not a question to answer in this webinar if it's okay, and we can follow up with you afterwards. But are there any other kind of immediate questions about anything that Adam or Vaughn or Catherine mentioned so far? I know it's a lot of information.
Yeah, and I think I will just quickly on Chris's question that I'll read for folks. Do you have a ballpark figure you base plans on for mass fatality or activating your FAC or CAC? I don't know, Adam, do you want to say a little bit about like just how dynamic and nuanced that is and what guides some of our thinking around that from an EM standpoint?
Yeah, so we do have, there's some facts and figures that we have from like the NTSB or the National Transportation Safety Board that we've seen. So when an incident involves X amount of people, how much capacity you should have for family, friends, support, that type of thing. So there's a little bit of a fundamental groundwork to know kind of what to expect. But it's not perfectly translated into a university setting. So I don't have those numbers in front of me, but in general, we have an idea of what to expect. And a lot of that is dependent on the scale of the emergency and, to be fair, the part of the university that it hits. So it could hit parts of the university and have little or no impact to, as far as the amount of population, and it could hit another part of the university, like say it hits a super block, and it would have detrimental impact and we would be overwhelmed really quickly. So there's a lot of moving factors with it, but we have a rough idea coming from the federal government or NTSB as far as an idea of what to plan for.
Any other questions quick? Can either put them in the chat or unmute yourself. All right, well, if you think of anything or if anything comes up in the group activity, we hopefully will have some time at the end to have some question and answers. So looking forward to that. So why don't we take about 5 minutes and come back at 2:15. Vaughn, are you going to be assigning people to breakout rooms during the break?
Yes.
Okay, so when they come back, what will they see? Will they still be in this big group or will they be in a breakout room?
You will all come back to this
Okay.
space first, and then I'll break you all up into the rooms.
Okay. Thanks, Vaughn. So we will reconvene at 2:15.
All right, we're gonna start to bring folks back. Okay. And some folks have not been able to stay, so if you end up in a room alone, we'll be circulating around. But if you end up in a room and other people have had to go, we'll kind of reassign you. What this activity is, I'm gonna stop sharing this screen and bring up another one. We have a situation, oops, there is a situation, where a tornado hits campus, and we'll put up, you know what, actually, we're gonna put a link to a Google document into the chat, and then we'll also show it, because once you get into your rooms, we won't share screens. And so a tornado hits campus, you are a member of the disaster behavioral health response team at the campus assistance center, and you're gonna meet a couple of individuals, group of friends that have gone through this and are now at the CAC. And there are some questions we want you to consider. This is not a report back and have a complete plan on what you would have done. You don't have to answer all the questions. You can have a deep discussion on one or two that really speak to you or bring up questions and concerns and actions. And we just kind of want to hear you apply what you've learned and what you think of all this. So I'm going to go ahead and send you to your rooms.
Hey, Catherine, hold on 1 second before you do that. So we're down to only 7 people in the Zoom. And you have 3 in the classroom. I'm just wondering, should we just maybe do it as a larger group and just talk through the scenario, and then you can keep it up on the screen? Or do you still want to try to break out into smaller groups?
We can try that. I don't know how well our in-person folks can hear people on the Zoom.
Oh,
It's
yeah.
a little, why don't we break? Well,
Okay.
because then we'll have 3 conversations. They'll get us a little bit of variety of what people consider and a little more kind of speaking time for everyone as individuals. And then we'll come back in about 13 minutes at 2:30 and report back and have discussion.
Okay.
All right, so I'm gonna send you all to your rooms. So I hit open all rooms, okay? Yvonne's coaching me. And then we'll send you the link to the scenario in the chat. So now I have to get the training vignette. Share. So I can broadcast. All right, and then
worried about her. Well, that was weird.
Especially just because you know, you can imagine it's just not well staffed, and so they're always needing people. But it was definitely, you know, heavy at times, and you know, I was saying like I definitely appreciate that partial kind of like requirement, though not required, just because I mean it would have been tough to sign up without that. But I'm really grateful for that experience, you know.
Substance abuse is public health crisis now.
Yeah.
Yeah.
So Catherine, we actually just got the chat link, so we had just been kind of having other conversations.
Gossiping. Yeah. And you're muted, I think.
Oh no.
I think we can hear you now, but we're in a little room with you.
Yeah, can you hear me okay?
Yeah.
Yeah.
Now,
Oh, okay. It says I'm on mute. So yeah, I apologize. We sent the document a few times. And now my screen is a little bit frozen, so I'm not sure what's happening. Maybe because I'm in the main room and this room with you all. So I apologize. Doing this, we were just saying, doing this virtually and in person, there's a lot to manage. So, yeah, take a look at the scenario. And yeah, I really was just popping in to see if you had any like questions or things you want to go through, but since you just got it, we'll give you a few minutes to take a look at it and see what comes up for you.
Well, I think I might have spoken too soon because I clicked the link and it just kind of brings me to a Zoom tab that then immediately closes out.
The link before that one.
I only see the one link in the chat
Oh.
yeah,
because
for me,
Mhm.
that's the only link and it doesn't work.
Ugh, okay. And I am,
Sometimes that's the way a disaster goes. You have a tornado and no one knows anything about it.
yeah. And now I'm getting a low battery signal on my, I thought this thing was also supplying power, but okay. Bear with us a moment here. Sorry, we'll check this out.
Title of the document.